Now, today we'll see the causes of anemia or low hemoglobin in chronic liver disease. Now, we know that whenever we see that it is chronic liver disease, we must understand it that the chronic liver disease can be diagnosed on the basis of USG. So normally the margins of the liver is pretty smooth. So very commonly when we get irregular margins of the liver, whenever we can see small nodularity on the liver, we can label it as that patient has CLD. So prominence of this nodularity, granularity on liver surface suggests the CLD. So nodularity is one thing. Second thing, if liver appears shrunken or small, then that also indicates CLD. The third thing is whenever we say that the caudate lobe hypertrophy is there, this also suggests that the patient has CLD. The other things like the portal vein hypertension also suggest CLD. Means whenever the portal vein is dilated and is more than 12 millimeter in diameter, we can say that there is portal hypertension and the patient has CLD. Other things like whenever the patient has perisplenic or periliver collaterals, development of collaterals which can be seen on ultrasonography or CT scan of the abdomen, we can say that the patient has CLD. Whenever the patient has esophageal varices, that is very commonly seen with upper gastrointestinal endoscopy, we can say that the patient has CLD. Very commonly, the patient may have portal hypertension gastropathy, which can be seen again on endoscopy, and this again suggests that the patient has CLD or cirrhosis. Most commonly, if the patient is alcoholic, if the patient has typical muddy faces or alcoholic faces where there is hyperpigmentation of the face, and if such patient very commonly presents with ascites, which is the most common presentation of CLD is ascites, that time also we can say that the patient has ascites. In any alcoholic patient or tobacco addict patient, if the patient has ascites and if the patient has hypoalbuminemia, in absence of a kidney disease or in absence of a protein loss in the urine, because protein loss in the urine usually suggests a kidney issue or kidney problem, a nephrotic or nephritic problem. But in absence of a kidney issue means if urine routine is normal, if there is no protein leak in the urine, then in absence of this kidney issue, if the patient has hypoalbuminemia, then in history of alcohol, tobacco, or bad lifestyle, it again suggests that the patient may have liver disease, chronic liver disease. Now, in such circumstances, whenever we diagnose that the patient has CLD on the basis of these findings, how do we or what are the causes for anemia in this CLD? Now we know the CLD, majority of the patients will be alcoholic or majority of the patients will be tobacco addict. So this alcoholism, tobacco itself reduce the appetite. These two bad addictions very commonly reduce the absorption of so many vital nutrients from the food. That is the reason why anemia can be very much common. For example, deficiency of vitamin B12 is extremely common in CLD. That can be because of the alcoholism, tobacco, or that can be because of the defect in intrinsic factor of Castle, which is very much evident in CLD. The other reason is folate deficiency, because we know that for the synthesis of RBC, we definitely need vitamin B12 and we need folic acid. And one of the most important ingredient for synthesis of RBC is hemoglobin, and for hemoglobin we need iron. So iron deficiency also is very common problem in the CLD because of the poor appetite, malnourishment, malnutrition. The other things which are there is presence of portal hypertension. Now we must know what is portal hypertension. This is the liver where the portal vein is entering, and portal vein is actually a combination of splenic vein and then superior mesenteric vein and inferior mesenteric vein. So we know as this liver is all shrunken, automatically there will be more pressure in the portal venous system. So, because of this portal hypertension, there will be hyperpressure into this superior mesenteric vein, inferior mesenteric vein, and splenic vein as well. So, in short, there will be congestion of the blood not only in the large intestine, in the small intestine, but also in the spleen because there is a congestion because of the portal venous hypertension, as around 70 to 80% blood flow to the liver is all through portal vein, and very little blood flow is through the hepatic arteries. So, as there is significant congestion because of the hypertension in this portal vein, these veins actually drain from small intestine, large intestine, and spleen. So obviously, as there is hypertension in the splenic vein, the spleen, which is basically getting drained into this splenic vein, what can only happens is there is congestion of this blood in the spleen, and that is the reason why there is increase in the size of the spleen. And this increased spleen size, this is abnormal increased spleen size, very commonly unnecessarily kills so many RBCs. So this is what we call it as hypersplenism. So to label it as hypersplenism, you need not to have a large size spleen. A normal size spleen also, in presence of this portal hypertension with the pancytopenia or anemia, is very commonly called hypersplenic action of it. So increased congestion. So increased congestion and inflammation mark so many immature RBCs, abnormal RBCs, defective RBCs, and they get killed significantly, which very commonly causes anemia. So hypersplenism is one of the most important reason for the anemia. Other reason, whenever we say that the patient has CLD, we very commonly have esophageal varices. So because of the esophageal varices, these varices very commonly tend to bleed very commonly. So patient very commonly may have melena that can be mild, moderate to severe in quantity, in intensity, and that may last for days, weeks, or months together. So there is chronic blood loss through this esophageal varices that very commonly causes melena. Other thing is, thus as there are esophageal varices, the patient may very commonly have increased stomach ulcers or gastric ulcers that very commonly causes blood loss, and that may also contribute to the anemia. The other thing is portal hypertension gastropathy, which actually is overall unstable stomach mucosa that basically doesn't have a very significant ulcer, but this very commonly has small defects in the gastric mucosa that tend to bleed more and that tend to absorb less nutrition, and that is one of the major cause of portal hypertension gastropathy causing anemia. So other reasons are such CLD patients tend to have very markedly reduced appetite. They tend to have poor lifestyle. They tend to have poor dietary choices. these things also tend to reduce the hemoglobin production, iron production, and it attributes or contributes to the anemia. Other reasons are these CLD patients, because of this, because of the so many reasons like fever or infections or lethargy or anemia, they tend to get investigated a lot, hospitalized a lot, and because of that, the blood is drawn multiple of the times for investigation, thing LFT, RFT, or hemogram, or other blood tests. So for that also causes direct blood loss to the patient, and that can very commonly cause the anemia. And in pregnancy, like menstruation, along with the CLD, patient may have anemia. So these are the almost all the reasons which very commonly contribute to anemia in chronic liver disease patients. Thanks you for listening, and that is all for today.